Hello, everybody. Good morning, afternoon, evening from wherever you are in the world. Welcome to today's webinar. Um, we have a great topic for you today here at the latest Sooma webinar. We'll be talking a little bit about what happened last year in clinical advancements in tDCS. My name is Ville Ansten. I'll be your host today. And without further ado, I think most people have joined. Let's give a couple, maybe seconds for the last people to join in before we get started. I can see that the number is ticking up there still. So let's give everybody time to connect before we get started. We have a pretty tight schedule today. There's a lot to talk about. But before I let Anne um, talk a quick practical matter. If you have questions during the webinar, there's a Q&A feature in Zoom. It should be available in the bottom of the screen there, so you can ask questions. We might have time to answer some questions at the end. We'll try and make time for that. So we'll try and pick some questions that you have. We received quite a lot of questions beforehand. If we don't address your question during the webinar, we hope to kind of get back to you later on that topic. But without further ado, again, welcome to Sooma's latest webinar on the clinical advancements of 2025. We have actually hundreds of participants in this webinar. It's a pretty big one for us from over 50 countries around the world. And our speaker today is Anne, our Sooma's clinical process manager and PhD in neuropharmacology. I'll give the floor now to Anne. Go ahead.
Thank you, Ville. Thank you for the kind introduction. And indeed, it is a wide topic to cover today. And I have tried to kind of focus on the indications that our therapies support. So let's start. So the idea is to go through kind of the recent clinical highlights in tDCS in depression treatment and in the treatment of chronic pain. And I will focus on the recent meta-analysis and also in the large controlled trials that were recently published. So as a background, I maybe want to kind of look a little bit back in the tDCS clinical studies. So tDCS has been studied for over 20 years already in the treatment of depression. And there has been a lot of good quality controlled studies and already, of course, a lot of meta-analysis that have concluded positively on the efficacy and safety of the treatment. But what is kind of important is that during the clinical studies, we learn and then we use these learnings in the next clinical studies. And one thing that has been developing is the length of the tDCS treatment. So the early study started with 1 week of treatment or 2 weeks of treatment. And it started to become evident that longer treatments are needed to get the optimal clinical benefits. So then these treatments developed further to 4 and 6 weeks treatments, and nowadays, like you will see soon in the latest trial, to 10 weeks. And then also some longer follow-up studies and maintenance studies have now been conducted that we will discuss today. And of course, this is very similar development in any depression treatment. So also for antidepressant medications, first the treatment periods were shorter and then they developed further to months of treatment. And the same has been seen with the magnetic stimulation, so that nowadays the treatments last for several weeks. And I think this study, this was a meta-analysis published a couple of years back that kind of summarized the current evidence that time, and to show that the clinical benefit is actually developing like until the 6 week and further in patients, and suggesting that longer treatments are needed. And it's not only in depression, so it's also in the chronic pain tDCS treatment studies. They are now starting to kind of look to longer and longer treatment periods, and of course, in part, this is possible because the tDCS devices have been now developed, like optimized for home-based treatments. So then it's actually feasible to study longer treatments and study these kind of a long maintenance treatments also. So what did the meta-analysis kind of conclude over the past year in depression treatment? So this is one of the depression meta-analysis, and indeed they kind of continue to conclude the same thing that the meta-analysis have been concluding already for several years, that tDCS is safe and effective. And now they are highlighting also kind of looking at the treatment protocols and the home treatments, and concluding that this is really simple to use and a treatment option that has a very beneficial safety profile. So in that sense, making it very, very appealing to clinical practice. So the effect size in this meta-analysis was pretty good, 0.65. So on average for antidepressant medications, for example, it usually goes between 0.3 to 0.5 or something like that in the meta-analysis. So the effect size has reached pretty good levels. And also it was now emphasized that combining tDCS with medication actually seems to provide additional benefit if compared with tDCS monotherapy. Of course, this depends on the patient populations that we are studying, so whether they are kind of more early stage depression patients where already the tDCS monotherapy it gives very good results, or whether they are these more difficult to treat, more chronic relapsing depression patients, where of course then the combination with medications would be then probably more effective. But as it is a safe treatment, because tDCS doesn't really have any interactions with medications, no systemic effects. So in that sense, it's a very feasible treatment to combine with different kinds of medications. What is interesting is that there has been now a few tDCS psychotherapy combination studies, and there it has been actually difficult to see statistically significant separation from the sham tDCS plus psychotherapy. But these studies are kind of also developing, so it's difficult. They have to be standardized in a way that how do you placebo control the psychotherapy and what kind of a psychotherapy is used and so forth. So this is something that we are very interested in following the science with this one, that will we see kind of later in the coming years that what is the best way to combine tDCS and psychotherapy to get really clear additional clinical benefits. So the factors associated with better outcomes in this meta-analysis came out. Well, first of all, the electrode targeting is the dorsolateral prefrontal cortex bilaterally. So this is, of course, what is nowadays used for depression treatment. And also it was pointed out that the 25 square centimeters electrode, so the smaller electrode, is better than the electrode that was used in the early days. It was a bit bigger, so it seems to be more effective, the electrode size that is mostly used nowadays. And also the acceptability is very good in the studies. So the dropout rates are below 10%, which is excellent for depression studies. And especially this is very important, that dropout due to adverse effects is actually less than 1%. So this is like a much better than what you see with antidepressant medication studies. And of course, this is because of the good safety profile. So the adverse effects are mostly mild to moderate, and they are transient, and commonly it's kind of mostly skin sensations and skin redness on the electrode area. And then there are headaches, and less frequently reported were dizziness, nausea, and sleep disturbances. But overall, no serious adverse events have been reported in the studies. So also this is in comparison to the medications or the other like brain stimulation methods. This is a very beneficial feature for tDCS. In this study, also other electrical stimulations were looked at. So this random noise stimulation and alternating current stimulation. And for random noise stimulation, there was very few data actually available. So you can't really kind of say anything about efficacy for that yet. And for tACS, it seems that it is associated with improvement in depression. And these are definitely these like different electrical stimulation modalities are something that we should be looking at in the coming years when more studies are finalized, that how does this their effect size develop. Another meta-analysis last year looked at the older adults depression treatment data, and indeed found that its tDCS is effective also this patient population. So because we know that the mechanisms are based on neuroplasticity kind of activities in the brain, so there has been discussion that is it then less effective in aged brain, where perhaps the neuroplasticity is different or is not so effective anymore. But indeed, it is effective in older adults, and actually the effect size was very good, so 0.96 when meta-analyzing that data. And safety was also very good, and actually this like the fact that there are no interactions with medications is very important in the elderly patients, because they usually have a lot of medications, and this was even looked at a bit more specifically in some studies. So combining tDCS with ECT or with SSRIs, and there were no additional or unexpected adverse effects found. So this is indeed very important treatment tool in the elderly patients. And then there was meta-analysis that tried to kind of, well, first of all, summarize the efficacy data, but then also suggest that what could we do still to improve the efficacy and kind of feasibility of tDCS. So what they found effect size of 0.4, and on the picture on the right side here, they kind of listed the effect sizes of different years. So here are the years, and then there are like all the studies published in that year. So what was the effect size, and what was the number of the participants in the study? So we can see that the effect size has been kind of a little bit varying between the studies. So these researchers wanted to kind of try to discuss that why are these results so variable, and what could be the features that we need to kind of understand better to reduce this variability and treat the patients more effectively. So first thing that they suggested is the stimulation location. So well, first of all, nowadays we know that the bifrontal bilateral electrode placement is the more effective, but still the kind of the individual differences between the tissues that the electrical current has to pass. So the, well, hair is one thing, then there is the skin, the skull, and then finally the brain tissue. So individual differences in those can change the electrical fields a little bit. And then these scientists kind of suggest that we should study that further, that could that affect the efficacy, and can we kind of target that better? And another thing that they kind of suggested to be optimized is the timing of interventions. So especially in those psychotherapy trials, the trials have been very kind of using different kind of protocols, whether they do the tDCS before or after or during these therapy sessions, and what kind of a psychotherapy is provided. So if we want to conclude on such combinations, we really have to think about the timing of tDCS. What is the optimal timing, kind of brain state for the therapy? And then, of course, we can still improve the protocols. Well, now we have the home-based protocols, which allow the longer treatment protocols. That has been a very important improvement. But also accelerated protocols are now being studied. So could we kind of do more than one tDCS session per day, and would it provide kind of more efficient outcomes, and especially to those patient populations that are more difficult to treat? So these were kind of interesting topics and targets for the future studies. And of course, also the kind of biomarkers. So could there be some biomarkers that could predict that which patient will benefit from this treatment, and also importantly, which patient will not benefit from this treatment? So those will be also key features to figure out in the future. Then there was this large controlled trial conducted with tDCS. This was actually, you might have seen this already earlier, because this was kind of available online already over a year ago, but kind of officially published in the early 2025. And what was important with this study is that this was home-based treatment and fully remote study. So the patients actually never needed to visit the clinic. All the treatment materials were sent to these patients to their homes. So this was a very important kind of test whether this kind of a treatment model could first of all be feasible and could be effective and safe. Important maybe is that in this study, the treatment-resistant depression patients were excluded, and this patient population was known, based on the previous studies, was known to kind of have maybe less efficient outcomes with tDCS. So now this study wanted to look at those patients who don't have TRD, and on the other hand, these study patients did have at least moderate severity of depression symptoms. So these were moderate to severe depression patients, but without treatment resistance. Also, the study used the 10-week protocol for the primary outcome, and tDCS was given as a monotherapy or added on an ongoing antidepressant medication. Altogether, 36 sessions were given in these 10 weeks. And the outcomes were excellent. So basically half of the patients reached remission by the week 10, which is really good result, of course, we have to remember that these were non-TRD patients, but this was an excellent kind of proof that this treatment works well already, like in the early stage depression patients. So the clinical response, that means that the symptom severity is dropped by at least 50%. That was reached by 60% of the participants. So really good results. Also, the acceptability and the safety outcomes were all very good. So there were no new unexpected side effects emerging with this home-based model and the kind of remote supervision model. So only the usual known side effects were reported at the expected rates. And what is maybe also interesting here is that when we look at the kind of treatment effect at early time points, so already at week 4, there was a significant clinical benefit from the active tDCS treatment. So this, and then this kind of effect got more pronounced until the week 10. And this kind of just shows us that some of the patients actually reached remission or the clinical response already during the first few weeks, whereas other patients kind of accumulate the treatment effect for a long-term period, so for 10 weeks or longer. So this is always important to remember, that the treatment effect from the tDCS is very individual, like any other antidepressant treatment would be. Then I was already kind of hinting that we will talk about the maintenance tDCS. So there were actually 2 maintenance studies published past year. And this is very important because we know that depression is a very commonly relapsing disorder. So there is the largest antidepressant medication study, the STAR-D study, showed kind of very painfully that half of the patients actually will suffer depression relapse within the 6 months after they get the treatment response. So in this study, the patients were followed for 12 months, and the patients were recommended to continue their effective medications so that they had responded to. And on average, by the 4 months time point, half of the patients had relapsed. So definitely we need to get better treatments and better maintenance treatments for these patients so that they would maintain their kind of good condition. So earlier studies on tDCS maintenance have been published, 2 of those. So 2 studies had 6-month follow-ups, and the first one had some maintenance treatments, but very few. So the acute treatment was only 2 weeks. And then after that, there was 1 session every other week. Of course, these studies were limited by the fact that the treatment was done at the clinic. So the patient always had to return to the clinic to get the treatment. So the maintenance schedules were quite modest, like not many sessions. And interestingly, what they found was that the patients that were suffering from refractory depression, they relapsed kind of badly. So by the 6-month, majority of them had relapsed. But then those patients who didn't have refractory depression, they actually maintained their treatment response pretty well, even with this pretty low intensity maintenance schedule. Then there was another study a few years after that had a little bit more intensive acute treatment and also more intensive maintenance sessions. So now there were 2 sessions per week for maintenance, and they did reach better results. So even those treatment-resistant patients now maintained their response better. So more than half of them were able to maintain the treatment response, and almost all, or let's say like more than 90% of the non-TRD patients maintained their response. So this, of course, these are not many studies yet, but they kind of suggest that the more intensive maintenance definitely benefited, especially the TRD patients. And of course, it was important that this long treatment was well tolerated and no like unexpected safety concerns were found. And now last year there was like a continuation of the RCT that published a couple of years back. So that study's follow-up phase was published last year, where they kind of concluded that this home-based maintenance tDCS was very, very feasible and safe and was clinically meaningful for relapse prevention. So the details of the study were, so the acute phase was 6 weeks treatment with 21 sessions, and then the maintenance phase had 2 tDCS sessions per week for 6 months. The responders from the RCT phase, so 71 patients were included in the maintenance phase, and then the outcome that they were looking at was the relapse or not relapsing. And this study had both TRD and non-TRD patients. And after the 6 months, 8.5% of the patients had relapsed. 15.5% had discontinued in the study. So this is always difficult in depression follow-up studies, that to actually keep the patients in the study. So often the patients discontinue before the 6-month follow-up time point. They did not find significant predictors for the relapse. And the adverse events were kind of the expected ones, so nothing new, predominantly mild, and mostly the scalp itching and some headaches. But actually, during this long-term maintenance of just 2 sessions per week, quite many, like 40% of the participants reported like that there were no adverse events at all. And then the trial that I just introduced to you, that was also continued with up to 6-month follow-up, and the follow-up was published also last year. So this is the home-based remote study that I told you about, the 10-week acute phase, and then the 10-week acute phase was followed with a 10-week kind of open label phase, so that all the participants were offered the active tDCS, and then at 3 months and 6 months, these participants who continued to this follow-up phase were kind of assessed for their depression symptoms. And so these were, to remind you, these were non-treatment resistant depression patients, and also that to the follow-up they actually took both participants who did not reach treatment response and those who did get the treatment response. And then here they didn't have like a set schedule so that everybody has to do some amount of tDCS sessions for maintenance, but they were able to do tDCS sessions during the maintenance as they kind of if they wanted. And about half of the patients actually did do tDCS during the 6-month maintenance, and on average, those who did, they did 1 to 3 sessions per week. So half of the participants decided that they don't need or don't want to do tDCS after the kind of 2 10 weeks periods during the first study. And here you see that the response rate was growing from the first 10 weeks to 20 weeks. So between 10 and 20 weeks was the open label phase when everybody got the active. So this is expected that now those who didn't respond maybe during the first 10 weeks or who got the sham treatment, so now their symptoms improved. And at 3 months and then at 6 months, the response rate got a little bit higher actually, suggesting that those participants who did not yet reach treatment response after 20 weeks, some of them actually got better in the following months. And when looking at the relapse rate in these patients, 95% actually were maintaining the treatment benefit, so of those who had got the treatment response. And only 5% suffered a depressive relapse, so very good result. But what was kind of intriguing was that they couldn't really point an effect to doing those tDCS sessions. So both patients who did maintenance tDCS and those who didn't actually maintained their treatment response pretty well. So of course this could tell us that patients were very well able to kind of decide when they needed to do maintenance tDCS to support their maintenance. But this is definitely like a treatment detail that we need to study more and learn more to find the optimal protocols for maintenance. But this already seemed to provide really good outcomes. And their kind of conclusions for safety and tolerability was very good. So those were just the common side effects that you usually see. And then when they were asking about kind of the satisfaction from the treatment, or acceptability, it was rated very acceptable, and the participants say that they would strongly recommend the treatment to others. And when asking about the effectiveness from them, they said at a 3-month follow-up, the average was quite helpful, and then at 6-month follow-up, it was very helpful for the patients. So very good appraisals. And now I'll try to kind of sum up the takeaways from those learnings for depression treatment. So the clinical evidence is providing more support for the efficacy and safety, and the 10-week treatment protocol provided very good results in the non-treatment resistant depression patient population. And then tDCS is effective and safe as a monotherapy, and also when combined to medications, and this is important for especially in the older adults, and also the efficacy was good in the older adults. And then the maintenance, so home-based long-term maintenance is feasible and is supporting the relapse prevention. So especially those patients who have treatment-resistant depression seem to benefit from maybe more intense maintenance tDCS. And it seems that 2 or 3 weekly sessions is better than one or none sessions during the maintenance. And then a little bit about the tDCS in the chronic pain treatment. So what did we learn from the recent studies? These are our CE certified indications. So chronic and neuropathic pain in knee osteoarthritis, fibromyalgia, multiple sclerosis, spinal cord injury, and phantom limb pain. But I will, in these slides, I will mostly focus now on these two because these were the ones that kind of where the meta-analysis or the most interesting studies were actually published last year. And there was several meta-analyses in chronic pain in knee osteoarthritis, and like again concluding that it is effective and safe, and now we have kind of both home-based and clinic-based studies existing. So both of those models were found effective, and also one of the meta-analyses was looking actually of the studies that were combining physiotherapy with tDCS and found that this combination actually increases the effect sizes. So the combination is beneficial to patients. And I would like to focus a little bit on that. So really interesting controlled trials were published last year on combining tDCS treatment to other treatment modalities for the knee osteoarthritis pain. So a couple of studies looking at the combining with TENS and both concluding with positive results. The other one had 6 weeks of tDCS plus TENS and the other one 4 weeks treatment, and both find the active tDCS combined to TENS to be superior to sham tDCS combined with TENS. And there was then a third study that combined tDCS with aquatic neuromuscular training, and also this was a positive study. So the combination with active tDCS was more effective than with sham tDCS. And I think that these are very important findings because on depression side, it has been sometimes difficult to kind of study different treatment combinations. But here, like already several studies have shown clearly positive outcomes with combining different modalities. And for pain treatment, I think that is very relevant and important that the patients get different treatment modalities to really effectively treat the pain. And then in fibromyalgia, there was a meta-analysis, and here is again a lot of text because they were extensively kind of looking at different details. They included a large amount of studies with that totaled a lot of participants. Most of the studies are done at clinic, so only 3 studies actually have used the fully like home-based tDCS in fibromyalgia. And the treatment length varies a lot. So the early studies were just with 5 or less sessions. And now the later and the home-based studies reach 60 tDCS sessions treatments. So a lot of variation between the protocols. The efficacy outcomes show that tDCS over the primary motor cortex or dorsolateral prefrontal cortex, so the depression montage basically. So both those electrode placements produce significant clinical benefit. And these seem to be short to mid-term reductions in pain and mood symptoms. So the studies that have follow-up phases suggest that after the treatment has been stopped, the pain kind of start to come back for many of the patients. The meta-analysis showed that longer interventions are better and of course, then they will have higher number of sessions. And this is one example from one of the home-based tDCS study in fibromyalgia, where they gave the 12-week treatment with 60 sessions. And they show that, for example, at week 4, there was like 50% pain reduction, but then after 60 sessions, there was a 60% reduction in the pain scores. So it kind of shows that the treatment effect accumulates after the first few weeks, even though many patients actually see very clear clinical benefit already after first week or first couple of weeks. But still, on average, the treatment effect will accumulate in a longer treatment. And the safety was like what has been reported earlier. So very good safety, nothing surprising came up. And there was also in fibromyalgia, there was a study last year published that looked at the combination of tDCS with other treatments. So this was combined with exercise and pain neuroscience education. And they got very good results. So the primary outcome was this kind of a multidimensional pain interference index, looking at different aspects of the disease and of kind of life. And there was a very clear separation from the sham tDCS with the active tDCS combined to those other treatments already after a couple of weeks. And still, actually, these groups separated still at the 3-month follow-up. So this was quite good outcome in a sense that it was a 4-week treatment, but these benefits did persist in some of the patients, even though some of the patients kind of did relapse. But some of the patients do maintain those outcomes in fibromyalgia. So the key takeaways in pain therapy is that the treatment protocol is 2 to 6 weeks at least of acute treatment, and home-based treatment is feasible and allows for longer treatments, because when you do longer treatments and more sessions, you get better clinical benefits. Still, the kind of duration of the effect is variable between individuals and different pain conditions. So that is something that, it just means that some patients will need very long-term treatments. So maybe even years. We know that some pain patients have continued for years because the pain does come back for them if they stop, if they fully stop. So they can do maintenance of, for example, two weekly sessions. And then we learned now that combining tDCS to other treatment modalities provides additional clinical benefits, which is really good kind of news for pain treatment. So at the end, a little bit of about Sooma. So we have been working more than 10 years to develop a very feasible, simple to use tDCS treatment for patients that they can self-administer at home, and that the clinicians are able to kind of easily also control and monitor how they wish. And maybe these are the important features of the product. So our device is capable of providing tDCS and also tACS. So for some experimental research use, and we do kind of support high clinical standards, but also on the other hand, we provide simple solutions so that they can be used at home environments. And we have very simple stimulator with one button, and with Bluetooth connectivity to a mobile application, so the clinicians can actually then monitor the treatments very closely. And our system also allows collecting data, so collecting assessment, some questionnaires, for example, PHQ-9. But yeah, I will stop now so that we have a little time for questions also. So thank you for your attention and for your time, and I hope you learned some new things today.
Thank you so much, Anne. We have some questions come in. Please, if you have any, the QA section is open. You can go write your questions there and we'll try and answer all of the questions that have come in. There's a couple of quite extensive questions that require, let's say, more time than we maybe have at this point to answer. If we don't get around to those, we'll get back to you. We have the email that you registered to this webinar from, so we'll be absolutely reach out to you shortly, like in the next couple of days. But I'll grab a couple of simple questions, easy questions here. So there's one question: would the stimulation protocol be different for pain compared to depression?
Sorry, can you repeat?
Would the stimulation protocol be different for pain compared to depression? So pain treatment versus depression treatment protocol.
Yeah, so they are a little bit different. So, well, first of all, the electrode location. So for the pain indications, we target the analog electrode to the primary motor cortex, which is like one of the key brain areas in pain modulation. So we try to kind of wake up the primary motor cortex to start suppressing pain signaling. On the other hand, in fibromyalgia, the primary motor cortex or the prefrontal montage, like the depression montage, has been found effective. Yeah, so the depression treatment is targeted to the forebrain, whereas the primary motor cortex is like the pain modulation area. And also the duration of the stimulation is a little bit different. So the pain stimulation is 20 minutes per day, and the depression is 30 minutes per day. But otherwise, the level of electrical current is the same, and the size of the electrode is the same.
All right. Next question. Knee osteoarthritis, is that done with the M1 or the DLPFC protocol, or montage placement of electrodes?
It's done with the M1. I don't now kind of come up with studies that would have used the prefrontal montage. So, of course, the electrical fields that these quite large electrodes create, so they are quite large. So they do overlap with many brain areas. And also the prefrontal montage can reach important areas for pain modulation, and also the mood is very central, like very key player in pain, chronic pain. So chronic pain patients often have depression symptoms, and when you have low mood, your kind of pain and expectations of pain are more severe. So they are like interconnected, but yes, the target for knee osteoarthritis pain is the primary motor cortex in our indication.
All right. Then there's a question. I'll roughly translate this to English, but the availability of equipment for private medical center clients. Is it possible to prescribe directly to the patient without the medical center having to purchase the equipment? I can maybe slightly answer this, that we do now have in the EU, in certain countries, we have a shop that you can direct your patients to, where they can purchase the treatment for themselves. It's a 6-month acute plus maintenance treatments package, and you can check that out. If you have any questions like about that further, then just reach out to us and we'll help you kind of with any of those that you might need. But that is a possibility now. A center doesn't necessarily have to purchase the devices for them to own to be able to prescribe the treatment to patients nowadays. Let's see. There was one question here. So, do the meta-analysis data suggest any difference between tDCS plus antidepressant medication and sham tDCS plus antidepressant medication? So, differences between tDCS combined with AD medication versus placebo TDC or sham tDCS with still antidepressant medication.
Yeah, so one of those meta-analyses that I kind of showed that was published last year, so they did conclude that the combination seems to be more effective than the monotherapy. But it's a difficult question because those studies have kind of very different patient populations. And some studies did not find more clinical benefit when adding with the medication. But on the other hand, then there are like head-to-head comparison studies that look at that exactly, that show that the combination does provide additive effect. So, I mean, the kind of latest meta-analysis does conclude that it would be beneficial. But I would suggest that that might be kind of in patients who are not maybe the first-line depression patients. So we really need kind of studies that standardize the patient populations then and then look at those combinations, that what is the most effective and safest combination.
All right, then there's a question/comment that the neuropathic pain wasn't mentioned in today's presentation. But Anna, would you still like to comment on tDCS specifically for neuropathic pain conditions?
Yeah, so let's say there were some meta-analysis there as well, but not many studies actually published last year on that. The earlier meta-analysis do support tDCS treatment in neuropathic pain. I mean, that is why we can have those certified indications. But I think that because the fibromyalgia is like there has been a lot of large studies, so that's why there are also now big meta-analysis there, and they are starting to look at these treatment combinations, which are very interesting. So that's why I wanted to focus there. And on the other hand, the knee osteoarthritis has provided really good results. So this is also why kind of you can see a lot of meta-analysis on that patient population. And I guess one thing is that tDCS is targeting like the central sensitization of pain, and that might be like a shared mechanism then in neuropathic pain or chronic pain in fibromyalgia, whether it is, I don't know, maybe it's not purely neuropathic, maybe there is some neuropathic features, but maybe the central sensitization is something that we are actually treating with tDCS. But yeah, that's a good comment that the pain is very complicated field, different mechanisms behind different pain conditions. But I think for us, for tDCS, like combining feature is the central sensitization that we want to try to affect with tDCS and try to kind of enable the brain to relearn modulation of the pain, like the healthy modulation. Yeah.
Right. There's a question that is Sooma medical graded devices. I'm like understanding this. Do we have like certification to which our devices are CE certified for use in Europe in depression, neuropathic pain, fibromyalgia? But if that didn't answer your question, please put a message in the chat and kind of we can come back to that. There's a ton of questions still. We still have a little bit of time, so I'll keep on going. There's a question on, would it be a problem to treat pain with basically the same protocol as depression, so 30 treatments?
The length, definitely, like the longer you can treat, the better. And of course, the patient, I have understood that in pain treatment, the patient quite quickly knows whether they are benefiting from the treatment. So they can feel the effects after 1 or 2 or some weeks. And if the patient feels at all that, yeah, I think I want to continue, that I think there is something happening. So definitely the longer you can continue, so the better. And then at some point, once you got the response, you then try to maybe reduce the stimulations and see whether the pain starts to get back and whether there is a level that you need to maintain to kind of treat the pain.
I think the basis of this question was that if a clinic has a device that they use for both depression and pain, could they technically use the same protocol for both indications? To which basically your answer that you just gave. And other than that, the only differentiating feature between pain and depression is naturally the placement of the electrodes, and the cap that we have takes care of that. So the cap can be customized to have the electrodes in basically any configuration on your scalp that you can think of. Depression typically is done on the DLPFC, the frontal cortex, pain on the motor cortex. But of course, off-label indications, study indications can be done. So if you want to place the electrodes basically anywhere around the head area, that is doable with the cap. And that's something that actually differentiates our treatments or our solution on how we apply tDCS to many of our competitors, which can only do a very limited number, possibly even just one different type of electrode placement. So then we have, what sorts of methods are being used to assess whether tDCS is beneficial for fibromyalgia?
Yeah, it's a good question. So the pain questionnaires and mood questionnaires, fatigue, very like sleep quality. Fibromyalgia is such a complex condition that so many kind of different symptoms, so many areas of life are affected, so you can measure many things. And then there are also these tests like pain thresholds and so forth that I often used in fibromyalgia studies. So a lot of assessments and questionnaires and tests.
So we have 1 minute left. We've got about 10 questions still. So if your question hasn't been answered, I apologize that we didn't get to it. We will kind of get back to you with an answer. I'll pick the final one from this list. This is a quick one. Are there any contraindications to the use of tDCS in patients with depression?
Yeah, so there are a couple of contraindications. So because we use electrical current, so there shouldn't be any metal or devices on the skull or inside the skull, so in the brain. And also the skin on the electrode area has to be intact. So the electrical current, and then there is a little bit of salt solution on the electrode pad. So those can irritate the skin. So your skin should be healthy on that area. basically those are the contraindications.
It's here 3 o'clock here in Finland. I hope it's not too early or too late where you're at. Thank you all for your time. If you want to have a discussion with us on maybe research, maybe applying it in a routine use, just send us a message. We'll book a time. We can have a call. If you're in Finland, we can come visit you. We'll make sure that that your questions get answered and you can potentially use tDCS to its full effect. We'd be more than happy to schedule that call. I know there's a lot of questions, a lot of like things to go over with tDCS, and as the questions here, the Q&A section showed, we'd be more than happy to discuss them with you in like more detail. But for today, thank you everybody. We'll be sending the recording of this at some point to all the attendees. So if you want to review something that was presented here, that is possible in a little bit. Otherwise, thank you so much, and I hope to see you in the next webinar.
Thank you all.